moment. So we're going to be talking about this topic, interdisciplinary investigations into the barriers and facilitators of something that we're calling Clinician-AI teaming in psychiatry. And so, as you know, you're here at this conference, there's been this proliferation and growing interest in the use of AI applications. I say that broadly because what we mean by that can be a lot of different things. We can talk about machine learning, we can talk about large language models. There's been a focus really on getting those, if I talk about machine learning right now, for example, getting those models right, which is absolutely a great place to be focusing attention. But let's pretend that those models are as perfect, as good as they can be. There's another element to being able to utilize those models in clinical practice, a few other elements to being able to utilize those models in clinical practice to support decision making. And that is an area that more and more work is being done. And so today's symposium will focus on some multidisciplinary lenses into thinking, okay, we've got this AI support for decision making. What are some of the things we ought to think about before we jump into making decisions based on some of that information? And that's where this term of AI teaming comes in, not sort of relying on sort of AI as the one making the decision, but teaming up. So we have a few individuals here who will be presenting some work done in this space from different perspectives. Dr. Marta Maslej is here, if you just want to wave for a second. Marta is a staff scientist with the Krembil Center for Neuroinformatics at the Center for Addiction and Mental Health. For those of you who have not heard of that organization, the Center for Addiction and Mental Health is Canada's largest teaching mental health psychiatric organization affiliated with the University of Toronto. She's also an assistant professor with the Department of Psychiatry at the University of Toronto, and her research involves using computational methods, derived insights from clinical data, including psychiatric notes, with the aim of improving assessment, informing treatment decisions, and identifying and mitigating bias. We also have Aksharaa. Do you want to wave? So I have to say the next two speakers I'm going to introduce, completely amazing that they're here, so thank you. Aksharaa is a fourth-year undergrad student in the Department of Psychology, so amazing that you're presenting your work at McMaster University, which is located in a city called Hamilton, just outside of the Toronto area. And her research experiences and interests lie in the field of experimental psychology, and she's currently a research student at the Center for Addiction and Mental Health with Marta. Okay, and I will introduce you next to Shrika, who is also, how amazing to be an undergrad and to be presenting, I have to say. I would have been, too scared. So Shrika Vejandla is a second-year undergraduate student at Queen's University, which is where I did my undergrad, studying health sciences. Shrika is currently involved in the Predictive Care Lab at the Krembil Center for Neuroinformatics at ChemH, and the TCURM, which is our AI in Health Center at the University of Toronto, medicine studentship recipient, working on examining the value of cognitive forcing for ethical AI implementation in acute psychiatric care. So welcome. And then finally, we have Ryan Chan. And Ryan is an assistant professor at the Arthur Labatt Family School of Nursing at Western University in Canada, which is in our London, not UK London. Ryan's teaching, research, and scholarly interests include digital mental health and nursing informatics, among other topics. He is the incoming president of the Canadian Nursing Informatics Association. And so the way this will work is similar to the last symposium that was done in this room. If you attended it, we'll do all the presentations, around 15 minutes each. And then we'll have some discussion and questions at the end. So we'll hold your questions between the presentations, and we'll have a more robust discussion towards the end. So on that note, I will welcome Marta.
Okay, So hi everyone, thanks so much for coming to this symposium. So my talk this morning will discuss bias as a potential barrier to AI implementation in acute psychiatric settings. And so as Gillian had mentioned, this work has been completed at CAMH, which is a psychiatric hospital in Toronto, Canada. So, we're all here because we believe that AI has potential to transform healthcare delivery. And as we've heard from some of the talks this morning, a popular goal in the area of mental health and psychiatry has been to develop these models that can discover patterns in data to predict different outcomes, but also different kinds of risks. So, like suicide, hospital readmission. We heard an amazing talk earlier about relapse or substance use treatment relapse, or substance use disorder relapse. And so the overall aim in developing these kinds of models is to support clinical assessment or decisions about treatment. But one major challenge that we grapple with in this area is that AI can sometimes produce inaccurate or biased information. And so we have been looking at this potential in one context, specifically at CAMH, which is the prediction of violence risk. So you may or may not know that inpatient violence is a major challenge in psychiatry. So these are Canadian stats, but 50% of psychiatric nurses in Canada have reported being targets of verbal or physical abuse from patients in recent shifts. And rates reported in reviews can be as high as 80% for any form of aggression experienced in psychiatric settings by healthcare providers. So obviously this is a challenge, and one way providers manage risk in this setting is to routinely assess their patients for their risk of becoming violent or aggressive, which can help them facilitate more timely or effective interventions. And there have been recent efforts to improve this risk assessment with machine learning. And so machine learning models have been trained on different data sets, including health record data, to try to predict this risk. And performance has ranged from areas under the curve of 0.6 to 0.8, so kind of reasonable. But our team was really concerned with the potential for bias in these kinds of predictions, given that there are social stereotypes about the kinds of people that might become violent or aggressive, or also systemic factors that can increase perceptions of risk for certain groups. And no studies or no machine learning studies have done fairness assessments to try to understand whether prediction errors differ by different groups. And so to address these questions, we did 2 studies, which I'll talk about today. So the first is a machine learning analysis of health record data from 10 inpatient units at CAMH at our hospital, which involved over 17,000 patients receiving acute care. And this was analysis that was completed by one of our students, Yifan, and it has been submitted to a journal. But essentially it involved collecting different kinds of data used in other studies as predictors of violence or aggression. And so these data included socio-demographic, clinical, admission, and risk assessment data, which were used as predictors of our outcome. And the outcome was a documented violent or aggressive incident in the hospital's reporting tool. Our outcome also included coercive interventions used to manage violence or aggression, like seclusions and restraints. And we and other studies have included this as an outcome because these coercive interventions are only really supposed to be used when violence is deemed imminent. And so the idea was to train models on these features to predict the patient's risk of becoming violent or aggressive. And we only made this prediction on the first 3 days of the patient's acute care stay because the research suggests that this is when these incidents are most likely to occur, and this is also something we had found in our data as well. So this slide shows a schematic of the training and testing process, and I won't go into detail about the machine learning modeling, but I'm happy to answer questions about it later. Essentially, we split our data 70-30 for training and testing. We trained various models, so we did simple models like logistic regression, but we also used more complicated models like neural networks. So we sort of kind of train the models on the training set with various forms of resampling because we had a very imbalanced outcome. So violence or aggression only really happened on the 3% of days, of the observation days in the analysis. And then we kind of selected our model on the train set, of course, with 5-fold cross-validation, and then we tested it on the holdout test set, or we tested the best performing model on the holdout test set. And really the key part was our fairness assessment, because we wanted to know whether the model would make more prediction errors on certain groups of patients that might be underrepresented or subject to these social or systemic biases. And because we were concerned about overestimated risks of violence for certain patient groups, we compared patient groups on false positive rates. So these are instances where the model says the patient will become violent or aggressive, but the patient doesn't actually go on to do so. And so, the overall performance that we achieved on the holdout test set with our best performing model, which was a random forest with a 200 estimator, with no resampling, surprisingly, was comparable to what's found in other studies, but you'll see that the sensitivity, so the model's ability to pick out the people that would actually become violent or aggressive, was not great, and this also unfortunately aligns with what's found in prior work. But on the bottom, you can see a figure that shows the false positive rates stratified by different groups of interest. So we stratified them by race or ethnicity, gender, admission type. So in our province, patients can be brought into the hospital by police for care under the Mental Health Act. So if someone's having a mental health crisis in the community, they can be apprehended by police and brought into the hospital. So mode of admission, or admit mode, refers to whether the patient came into the hospital with police or in some other way. And then we also looked at housing status as well. And so you can see that the false positive rates, so the model was more likely to predict that patients who self-identified as Black, Middle Eastern, or Indigenous had higher false positive rates. Men, also patients that were brought into the hospital by police, and also patients who were in unstable housing or unhoused. And so it does seem like machine learning may overestimate risk for racially marginalized or structurally disadvantaged patients. And why? So there's lots of reasons for this. One that we're particularly interested in is related to how patients are admitted into the hospital. So I mentioned earlier that there were higher false positive rates for patients brought in by police. And so this can be a factor that gets used by staff as a cue for potentially violent or aggressive risk. But we also know, and the literature shows, that there can be racial and residential profiling by police in the community around who gets apprehended for care. And so it could be the case that racially marginalized patients or patients who are unhoused are more likely apprehended by police for admission. And if this gets used as a cue for risk, then this could account for overestimated violence risk predictions. And so, obviously these sorts of findings are not unique to our setting. AI has been shown to provide biased or inaccurate information in various health contexts. And so this has led to the recommendation that in high-stakes settings like healthcare, AI shouldn't be used to prescribe or automate decision-making, but it should be used to support or augment it. So it's this notion of clinician-AI teaming that Dr. Strudwick discussed earlier. And we've also heard the term human in the loop. This is also often used as a way to describe that humans should always be aware of what AI is doing and kind of modulating their own kind of reliance on these systems. But an important benchmark for evaluation is therefore that the performance of the clinician-AI team must be better than performance of the AI or clinician on their own. And so our next study, we wanted to know whether teaming could safeguard against biased AI recommendations in a violence risk prediction context. So if we had a biased AI or machine learning prediction and we threw a human in there that was like kind of overseeing it, would this actually help prevent or mitigate bias? And so to answer this question, we completed an experiment to examine this question. So we had a large team on this. Shrika and Aksharaa, who are here today, also helped with this study. And we recruited 281 participants online to complete a decision-making task supported by AI. So we did use a crowdsourced sample for this. It wasn't a sample of clinicians. And the task of participants was to read 8 different descriptions of mental health emergencies. So one is shown here on the screen. Essentially, these were vignettes that described, people in mental health crisis, and calls were being made from concerned neighbors, for example, And the scenarios also provide a little bit of a backstory about the person and what was happening. And so participants read each of these, and then they were instructed to make a decision about which resources would be most appropriate for dealing with the scenario, either medical help or police. And participants were instructed to only deploy police if they thought there would be a risk of violence or aggression. And also they were supported by an AI recommendation. And the key factor here is that across scenarios, the demographic characteristics of the depicted individual were switched between what we thought were groups that were at high risk of unfair machine learning predictions. So these were groups that were racially marginalized or unhoused or had very specific diagnoses. Or the scenario may have depicted a person that wasn't at risk of an unfair prediction based on our prior research, so people who self-identified as white, were housed, or had a depressive disorder, or a woman. And then the other key factor here is that participants were randomized to either an unbiased AI or a biased AI condition. So in the unbiased AI condition, the AI recommended police deployment for 20% of any group. And in the biased AI condition, it was 20% for the no-risk groups, but 50 to 90% police deployment for the at-risk groups. And this is a simulated scenario, of course, so the AI didn't, we made up the AI recommendations to see whether the AI recommendation would influence people's behavior. And so for our results, we essentially ran logistic mixed effect models to see condition by risk group interactions. So the idea was, again, to understand whether the AI recommendation would increase police deployment, but only for the high-risk groups, since it was biased against those groups. And so we did have main effects of both condition and risk group, but also a significant interaction. So when we looked at the odds for deploying police for high versus no risk groups separately in each condition, you can see that there was 51% higher increased odds of deploying police in the bias AI condition for the high-risk groups, but there were no differences between the high and no-risk groups. So essentially, this just means that people were more likely to make biased decisions in the presence of biased AI recommendations. Probably not that surprising. But when we ran some secondary analyses, like fitting the same model separately for each depicted demographic or clinical characteristic to determine if findings were restricted to a specific demographic group, we found that this interaction was only statistically significant for the Black versus white depicted groups. And essentially, this means that people were almost 3 times as likely to deploy police for the Black versus the white group in the biased AI condition. So the effect of the bias really only extended to the demographic comparison of white versus Black and not some of the other high-risk group that we were interested in based on, say, gender or housing. So yes, it does seem like biased AI recommendations may lead to biased decisions. And of course, both of these studies had some limitations. So some limitations of the first machine learning study was our focus on the false positive rate. In fairness, we had a very specific Canadian context and sample, and our model had poor sensitivity overall. And of course, in study 2, the limitations were our use of a crowdsourced sample, so these weren't clinicians, so this kind of calls into question potentially quality of the data, but also generalizability. But we did do an attention check because we were worried about the data quality, so we excluded participants who didn't pass our attention check. But I think overall we can sort of conclude that machine learning may overestimate risk for racially marginalized and structurally disadvantaged patients, and biased machine learning recommendations can lead to biased decision making. And so this calls into question this idea that human in the loop will be an effective safeguard against biased AI implementation in acute psychiatric care. And it's also important to note that another important caveat when we do consider evaluating the performance of the Clinician-AI team is that this has to be done under realistic conditions of the care setting. And we know that these settings can be very busy, stressful, and hectic. So it's really important to understand factors related to this setting that would sort of impact people's reliance on biased AI recommendations, and we'll hear a bit more about that in the later presentations. Yeah, so I just wanted to conclude by thanking my team And also emphasizing the importance of interdisciplinary collaboration. We're really lucky to work with a lot of people with diverse expertise from social science to computer engineering to psychology, which you'll hear more about today. So we have a lot of amazing collaborators in these areas. And I think this topic of AI implementation really requires a lot of different perspectives to really do it responsibly and correctly. So I think that brings us to the next topic. So this is Aksharaa and Shrika, who will actually present together. So it's a little bit of a different format, but their topic is pretty highly interrelated. So they'll talk about the impact of emotions and cognitive forcing on AI-assisted clinical decision-making.
Hi, everyone. Thank you for joining us today. My name is Aksharaa,
And I'm Shrika.
and as Marta described, we're going to be talking to you about potential factors that may impact the way that clinicians may engage with AI recommendations that can potentially be biased and how that would affect their decision-making outcomes. And specifically, Shrika's focusing on cognitive forcing, and I'm focusing on the role of emotions. So before we get started on our research topic, I wanted to give a brief overview about theoretical foundations that we use to design our research study. So firstly, a lot of our factors were derived from human-computer interactions, which is a really interdisciplinary field that looks to make interactions between computers and humans more engaging, efficient, and convenient. And this has a wide range of applications, including video gaming, in which you can think of making gaming controls more fluid and easy for gamers to use. But there's also multiple applications in healthcare. And an example would be electronic health data records. So AI can be used to make patient health records be presented in more organized and understandable methods to clinicians to streamline processes. And another important outcome of HCI in healthcare that we would consider is clinical decision making, as Marta described in her previous presentation relating to assessment, diagnoses, and specifically violence risk estimations is what we look at, and specifically bringing attention to the process of human AI or clinician-AI teaming in healthcare. So when we think about collaborative decision-making, this essentially involves the clinician and the AI working together and leveraging their strengths to create better decision-making outcomes in terms of precision. So one thing to consider is that when you're implementing AI into healthcare and considering the fact that these systems may be biased against marginalized populations, the outcome of clinical decision-making assisted by AI has very real implications in terms of patient populations. So the implications of applying human-computer interactions in video gaming, for example, and in healthcare are very different and should be taken very seriously. So when you're considering successful human AI or clinician AI teaming in clinical context, we have to emphasize critical engagement with the AI system by the clinician to be able to recognize when the AI may be incorrect or biased, and also not to use AI as a singular tool and to consider it alongside clinical expertise and knowledge, so that that prevents over-reliance on the AI recommendation.
Okay, and with regard to human AI teaming, the AI that we're specifically looking at is conducting a binary prediction of either the presence or absence of inpatient violence or aggression. And so this binary prediction is something that clinicians might use to delineate treatment and resource allocation or improve patient and staff safety. However, as we learned, this human AI teaming can be impeded by clinicians potentially over-relying on these biased AI recommendations, especially since bias can be a heuristic for managing busy and stressful clinical settings. And so given this possibility, there's a need to identify HCI factors that might modulate the impact of decision-making in the presence of these biased AI recommendations. And so the rationale for looking at these HCI factors can be looked at through the dual process theory of cognition, which posits that individuals mostly operate on system one thinking, which is faster, more heuristic, and could potentially give rise to over-reliance on these biased AI recommendations. And obviously that can be like a good thing if you're short on time, but at the same time, it could also reinforce these health inequities that gave rise to the biased AI recommendation in the first place. And on the other hand, there's system two thinking or analytical thinking, which involves like more deliberate decision-making and also necessitates increased effort. And so this could potentially mitigate the over-reliance on these biased AI recommendations. And there's also individual trait-like factors that might impact someone's propensity to engage in critical reflection. Specifically, there's a need for cognition, or NFC, which is a self-report questionnaire that's looking at someone's motivation for engaging in critical reflection, so whether or not they're motivated or like whether or not they enjoy engaging in critical reflection. And so those with a high need for cognition may be more likely to engage in system two thinking. So given these differences in thinking overall, there's an interest in looking at ways of framing AI that could potentially shift thinking in a clinical context from system one to system two.
So we're going to give you a brief overview of factors that we've derived from fields of experimental psychology and human-computer interactions that may influence over-reliance on potentially biased AI recommendations. And just so you know, the examples you see on the right are just examples from an experiment that we plan to run. And we divided the factors by whether they would be predicted to increase reliance on AI recommendations, meaning promoting type 1 or heuristic thinking, or factors that would be predicted to decrease reliance, so factors that promote type 2 or critical engagement. So to begin, for factors that increase reliance, we're interested in looking at AI attitude, and that is essentially the perceived accuracy of the AI recommendation provided by either a fellow peer or the AI itself. And we have conditions of high and low accuracy. So we predict that essentially if a peer gives a high recommendation of the AI accuracy, then people will be more likely to rely on it, but they will essentially be less influenced by the AI's estimation. Another factor is the anthropomorphism of the AI, meaning the degree to which it takes on human-like traits. And as you can see from the example, in one condition, the AI recommendation would be provided alone, but then in other conditions, it would gain a human name and perhaps a profile picture. And we essentially predict that the more anthropomorphized the AI gets, the more individuals will be likely to rely on it. And then finally, there is emotion. There is a lot of research in experimental psychology that shows that heightened feelings of anger, disgust, anxiety, and fear can promote heuristic thinking and thereby increase reliance on pre-existing biases, leading to biased decision outcomes. And there's also a note to make about emotions maybe decreasing critical engagement with AI recommendations and resulting in over-reliance on them.
And so there's also, like based on prior HCI work, factors that we think could potentially decrease reliance on biased AI recommendations. Firstly, the way that the AI is framed can modulate reliance. So so prescriptive framing, wherein the AI tells the user what they should do, so there's like an imperative action, is associated with increased reliance as compared to more descriptive forms of framing, which might just involve like flagging a patient for risk. Additionally, conveyed certainty is associated with increased reliance. So presenting the AI recommendation alongside a high probability score or indicator could increase reliance, especially if clinicians have like an idea going in of what they think is a confidence score that is too low. Additionally, there's explanations. So accompanying AI recommendations with a list of the features that drove the prediction could improve critical reflection. However, of course, this approach depends on the listed features being comprehensive. So if there are any factors such as patient demographics that were important to the model but were left out, this could potentially mask bias. And based on prior work, there's also inconsistent findings on the impact of the length of the list on modulating reliance on these biased AI recommendations. So it's unclear whether it's better or worse to have the explanations list be longer or shorter. And lastly, there's cognitive forcing, which intends to slow down the process of decision-making and promote critical reflection. And I'll be going into this in better detail later on during the presentation, but some cognitive forcing methods might include just letting the user decide if they'd like to see the AI recommendation, making them make a decision first, and then letting them update their decision afterward, or just delaying when they see the AI recommendation, so making them like wait for 30 seconds, for example. But before we go into that, Aksharaa is going to describe the HCI experiments that we ran looking at emotions and the impact on relying on biased AI recommendations.
All right, before I go into emotions, I just wanted to make note that these factors have been derived from research that doesn't necessarily meet the context of healthcare and specifically mental health care. So our experiments are essentially hoping to contextualize these factors with clinically assisted AI decision-making relevant to potentially clinical populations. So let me get started. So before I get into my experiment, I wanted to present on a little bit of research that shows the role of emotion in decision-making, specifically in a social context. So there's one study that assessed the impact of induced anger and sadness on biased decision-making in social domains. And to be able to assess the effect of emotion, it first needs to be induced. And there are multiple methods to go about this, but the way these researchers decided to do that was autobiographical memory. So they asked participants to reflect on a time when they were extremely angry, sad, or experienced a mundane event that didn't elicit much emotion. And following the recollection, they were asked to describe the event in detail. And essentially what this did was that through recollecting an emotionally charged memory, the participant induced themselves with that emotion. And it was validated, and researchers made sure that the emotion actually was induced. But following the induction, participants were shown case studies of an alleged misconduct, and these case studies were contextualized to university settings because participants were university students. And the main differences between these cases of alleged misconduct was the demographic of the individual shown. So there was a stereotype and a no stereotype condition. And in the stereotype condition, the demographic of the individual was Hispanic compared to non-Hispanic. And following that, participants made judgments on the perceived guilt of the offenders. And these case studies had mixed results, so there was no objective answer. So the ratings of guilt were completely dependent on the subjective interpretation of participants. So for the results, this is a graph of guilt ratings by the induction condition. And you can see that when participants were induced with anger, they were much more likely to rate the stereotyped individual or the Hispanic individual as more guilty compared to the non-Hispanic individual. And this effect was not seen with neutral or sad inductions. So the conclusion that can be drawn is that the experience of anger does increase heuristics by the reliance on implicit social biases, and that can result in outcomes like this in which there is a bias towards stereotyped individuals. So another study looks at disgust and interpersonal bias in clinicians versus non-clinicians. And what they did was that they measured the trait-like tendency to experience different types of disgust, including pathogen, sexual, and moral disgust. And they had participants, after the rating, read a case study about a fictional group of immigrants who were from Central Africa and then recently immigrated to America, and participants rated the immigrant group on cleanliness, trustworthiness, likability, and a few other measures. And for results, participants with a higher tendency to experience specifically pathogen-related disgust rated these immigrant groups as less likable and more unclean. And clinicians did tend to experience lower levels of pathogen-related disgust overall compared to non-clinicians, but they still showed the same interpersonal bias towards clinicians. That was the name of the immigrant group. But what can be derived from this is that essentially clinicians do report encountering scenarios that elicit disgust pretty commonly, and if these emotions are unintentionally affecting patient care, there needs to be more emphasis put on the experience of these emotions and the role that they can have on decision-making. But there's also research that shows that there's something that can interfere with the effect of heightened emotions on decision making, and that is emotion regulation. So participants who are better able to emotionally regulate, specifically by identifying the emotion and its source, are better able to reduce the bias in their decision making and also increase the accuracy of the decision making. And this is thought to be because of the ability to control the effect of bias on their emotions through compartmentalization. So this just stresses the importance of self-awareness and being able to emotionally regulate during heightened emotion. Okay, now finally to the study. We essentially ran a study very similar to the one that was described in the previous experiment, but we added mood inductions to see whether induced mood would have an influence on the tendency to deploy police for at-risk individuals. And before we got to the study, we actually had to create and validate mood inductions based on previous research. And there are different ways of inducing emotions, and different emotions have better ways to induce them. So for calmness, anger, anxiety, and disgust, which were the 4 emotions that we wanted to induce, imagery worked for the first 3. And what I'm referring to is essentially descriptions of scenarios in everyday life that can elicit one of the 3 emotions. And these are scenarios written to essentially make the individual reading it put themselves in the shoes of the person in the induction and kind of visualize themselves in that situation. And for disgust, there was a visual inductions are more effective for disgust, and we did have one. I'm not going to describe it because it is disgusting, but yes. All right, so how the experiment worked was that we had participants randomized into one of the conditions, so they were shown one of the inductions. And following that, they had a writing task in which they had to reflect on the emotions that they felt and how they would feel if they were in the shoes of the person that they read about in the induction or watched. And following that, we measured their emotionality through the discrete emotions scale. And basically for data analysis, we compared their emotion ratings on the scale to their induced emotion to see if the induced emotions would have an effect on their emotionality. So this is one of the results for our induction, and essentially all the inductions are on the x-axis and the scores for the emotion measure are on the y-axis, and each score is relevant to the induction that was given. So for example, in this example, you see that when calmness is induced, the calmness score of individuals or participants is significantly higher than of the other inductions. And then we see similar results for the other inductions. So for anxiety, we had 2. So in the in the second and third box, and we see that the second anxiety induction is more effective. And there's also a heightened anger in the induction, which is kind of normal because it's really difficult to induce a singular emotion, especially because anxiety is not discrete. And then similarly for disgust and anger, but for specifically the disgust one, we did find that our visual induction was more effective than an imagery-based induction that we provided. So we chose the most effective inductions from our mood induction study and moved forward for our main experiment. And in this experiment, it was very similar to the first experiment in which call summaries were shown, but first individuals were induced with one of the 4 induction conditions, and they completed the writing task. And then following that, they completed the call summary task that Marta described, in which they were asked to read vignettes about mental health emergencies and make decisions on whether police should be deployed or medical help should be deployed based on their estimation of the likelihood of violence. But there were 2 main differences in this experiment. The first being the demographics of the individuals depicted. So we only had one risk group and one non-risk group based on the experiments that Marta described. And the risk group was Black individuals and the non-risk group was white individuals that were depicted. And then also we didn't have a biased or an unbiased AI condition. All AI recommendations were biased to deploy police for Black individuals. And we essentially wanted to see if these induced emotions would increase the propensity to deploy police for the high-risk individual. And then finally, participants completed a questionnaire that assessed their demographics, the degree in which they trusted in AI, their familiarity with AI and how it works, and the degree to which they think that bias affects decision-making assisted by AI. And just to go over our hypotheses, we hypothesized that being induced with anger, anxiety, and disgust would be associated with an increased likelihood to deploy police for the high-risk group. And we also predicted that overall, there would be a tendency or a propensity to deploy police for the high-risk group because of the presence of biased AI recommendations. Okay, so for results, we ran a mixed effects model assessing the interaction between condition, meaning the different inductions, and the risk group, which was Black or white individuals. And we did not find any significant interaction between condition by risk, meaning that being induced with anger, disgust, or anxiety did not significantly increase the propensity to call police for the at-risk group or Black individuals. And then, considering the interactions were not significant, we ran another model just looking at condition, which is the inductions, and risk group as main effects. And we did not see a main effect of condition, but we did see a main effect of risk group, which essentially means that there was an overall propensity to call police for at-risk individuals. And this is just an odds ratio graph, kind of showing that the odds of deploying police by condition and risk, and we see the confidence intervals for each are in the horizontal line. So we see that the emotion inductions were not significant, but the effective risk wasn't significant. And the odds of deploying police for Black individuals exceeded white individuals by approximately 22%. And finally, I just wanted to discuss some theories I've had about why we didn't find an effect of induced emotion on biased decision-making. And one thing is the actual presence of biased AI recommendations, because a lot of experimental psychology research has found that emotion does promote heuristic thinking and thereby biased decision-making overall, but perhaps the presence of biased AI recommendations increasing the overall bias of participants made the effect of emotion insignificant. And this is an interesting line of relationship that I want to think about. And maybe in future research, I can examine the influence of emotions on decision-making versus AI by inducing participants with their respective emotions, but then running the call summary task with and without the biased AI recommendations to first check whether emotions do affect decision-making in this context, but also to see the degree to which AI adds increased bias if it is biased. And the second thing I wanted to bring up was the potential role of emotion regulation in decision-making. So we know that people who feel heightened emotion and are able to emotionally regulate by identifying the emotion and its source are able to not let it impede their decision-making. And in the call summary task, after reflecting, perhaps the written summary task in which they had to write about their emotion and how they felt allowed them to engage in this process and compartmentalize their emotions, and therefore the effect on decision-making wasn't as strong. So I would be really interested in looking at individual differences in, first, emotional reactivity, how much people experience emotions and intensity, and also individual differences in the ability to emotionally regulate when considering the effect of emotions on decision-making, and especially when it's assisted by potentially biased AI. All right, thank you. I will pass it on to Shrika to talk about cognitive forcing.
Okay, so to examine the impact of cognitive forcing as an HCI factor on mitigating biased decision-making in the presence of biased AI recommendations, we ran a human-computer interaction experiment looking at its impact and also evaluated participants' need for cognition. So we recruited 373 participants via crowdsourcing on Amazon's Mechanical Turk, and similar to the experiments previously described, participants read 8 vignettes about patients experiencing different mental health emergencies, and they chose to either deploy police if they believe that there's a risk of violence, or medical help if they believe that the patient's health is at risk. And so these two options acted as a proxy for a potential inpatient evaluation of risk that might happen. And vignettes were also supported by biased AI recommendations, which more frequently suggested police for Black patients as compared to white patients, because we were informed by the experiment described by Marta in that this was the pairing of the non-risk and the at-risk group that was significant. And after the decision-making task, participants completed the need for cognition questionnaire. Importantly, though, participants were randomized to one of 3 cognitive forcing interventions or a control condition. So in the control, the participants made the decision, or they saw the AI recommendation immediately after reading the vignette and then chose whether to deploy police or medical help. In the first cognitive forcing condition, delay AI, they saw a loading screen for 30 seconds and then they saw the AI recommendation and made their decision. In the update AI condition, they read the vignette and they immediately made an initial decision, and then after seeing the AI recommendation, they chose whether or not they'd like to update it. And lastly, in the AI on demand condition, participants chose if they'd like to see the AI recommendation or not. And we hypothesized that all the cognitive forcing interventions would decrease reliance on the biased AI recommendations, which in the context of our experiment would be seen through a decreased likelihood to deploy police for the Black patients. We also hypothesized that those with a high need for cognition score would be further benefited by the need for cognition interventions, in that they'd be even less likely to deploy police for Black patients compared to those in the low need for cognition group. So for analyses, we ran logistic mixed effect models looking at the condition by demographic group interaction. And on the whole, we were consistent with the previous experiments in that participants were 68% more likely to deploy police for Black patients, so they made biased decisions in the presence of the biased AI recommendations. However, the condition by demographic group interactions were not significant, so cognitive forcing actually did not mitigate the biased decision making. We then conducted a median split of our data set to separately examine those with a high and low self-report need for cognition score. And so in the low NFC group, the findings were similar to the overall sample in that participants were more likely to deploy police for Black patients, so they made the biased decisions in the presence of the biased AI recommendations. And we think that this could be potentially because they're more likely to depend on system one thinking, or rely on the AI as opposed to their own reflection. However, in the high NFC group, it's different in that they did not make the biased decisions in the presence of the biased AI recommendations. And this could be maybe because they just relied on their own thinking, or they were more likely to just ignore the AI recommendation, or they were able to identify that the AI recommendations might have been biased and then were able to calibrate accordingly. However, for both groups, cognitive forcing interventions did not impact their likelihood to deploy police for Black patients only. And so, given these findings, despite prior HCI work in which cognitive forcing interventions mitigated inaccurate decision-making, we think that perhaps in a mental health context, cognitive forcing interventions may not work to mitigate biased decision-making. And it might also be just not feasible, as informed by review findings on translating cognitive research into clinical or acute care environments, since it's preferred or more constructive to develop adaptive systems that maybe respond or anticipate errors as opposed to adding a new level of complexity in an environment that already features increased cognitive engagement. And our key finding was also that those with a high self-report need for cognition score, so those who said that they enjoy engaging in cognitively engaging tasks, did not make the biased decisions in the presence of those biased AI recommendations, but those with a low self-report need for cognition score did. However, despite this finding, some prior work on clinicians and need for cognition suggests that those with a high need for cognition had comparatively more impaired decision-making after a night shift caused by fatigue, probably because they typically rely on their own thinking, and this was disrupted by the fatigue. So despite our finding, this could mean that in a practical, clinical care environment or in an acute environment, the way in which individuals interact with AI can change over the course of a shift. They might not have relied on the AI as much at the beginning, but over time they do just because of time and resource constraints or fatigue. But at the same time, other findings on clinicians has found that those with increased experience, like years of experience or seniority, are less likely to use exhaustive searches for solutions, and they still maintain their mindware for effective problem solving or their accuracy. So this impact of fatigue and need for cognition can be stabilized to some extent that we're not sure of by seniority or experience. And so some limitations of this study include, as Marta mentioned, our use of a crowdsourced sample as opposed to a clinician population, and as well as the call summary task, which acted as a proxy for the inpatient risk assessment that could potentially occur. And for future work, we are thinking of using a clinician population as well as examining the impact of fatigue by either increasing the task complexity or adding in working memory tasks, imposing time constraints, or other methods to impose a workload, and stratified by NFC to see if findings are similar to what we found in the experiment. And on top of that, this was the first experiment to have been done looking at cognitive forcing in a mental health context. And we think that cognitive forcing should maybe not be implemented at the point of decision making for all patients, but rather during trainings, debriefs, or for patients at the greatest risk of biased assessment as a flag. And so these alternative forms of cognitive forcing might support incidental learning or the use of AI more in training to support accurate or equitable decisions over time. And with that, we'd like to thank our supervisor, Dr. Marta Maslej, as well as the Predictive Care Lab and our funding, as well as everyone for listening to this. Okay, okay, thank you. Okay.
Hello, everyone, and good morning. I think we have a couple minutes till noon. So as Gillian mentioned, my name's Ryan. Currently, I'm a teaching faculty member at the School of Nursing, and I'm also doing some of my traineeship at the Center for Addiction and Mental Health. And before I start, I just wanted to ask a quick question, and as you may potentially suspect from the title, anybody in the room would like to publicly declare that they're a qualitative researcher? Oh, it's okay. Well, maybe you'll change after. No, I'm kidding. So this work is primarily a qualitative study looking at some of the components and contributions related to machine learning decision support systems and how it potentially feeds into some of the different elements that was discussed earlier in this symposium. And so before I begin, I would like to acknowledge the support and resources provided by the School of Nursing, by the Center of Addiction and Mental Health, as well as by the Social Sciences and Humanities Research Council of Canada for this work. And so in my portion of the presentation, this is a brief outline. So I'll provide a little bit of the background and overview, not necessarily about all of the concepts, but also a little bit of the study in and of itself, looking at some of the study methodology, and then sharing some of the findings related to the study, and provide some discussions and implications that will hopefully segue into the question and answer period. So as a qualitative researcher, I'm always fascinated by stories and interested in stories. And I think for my story is how I sort of began my interest in this research, particularly in informatics. Certainly my clinical training as a nurse in the emergency department and my formal education as a nurse didn't really align with the concept of informatics. And it's often really hard for me as an undergrad nursing student to see what are some of the connections that I can make with informatics. And so, but when I started practicing, one thing that continuously amazes me is how nurses and other clinicians and other healthcare providers make decisions within a clinical setting. It always amazes me they just, knows what's gonna happen, what this patient is gonna do or how they're gonna do, and particularly in Merge where everything is so time sensitive, being able to say oh, how did you know they were, for the lack of a better word, going down the drain, etc. And I was always fascinated by that process. And so over time, learning about, not only my nursing practice and developing my knowledge and skills in that area, but also, coming to learn of AI and machine learning. And that its unique capabilities in forming predictions and providing recommendations. So that's where I began to see some of the similarities with some of the work that clinicians do on a daily basis. And so the interaction of the two really sort of led me to think about conducting this research as part of my doctoral work. So as a brief overview, and I'm sure many individuals in the room would be quite familiar, is, machine learning is a subset of AI, which really focuses on a lot of, self-learning capabilities, predictions, through analysis and pattern recognition, et cetera. And one thing I will say, as an informatics researcher at this particular moment, I'm not very well versed. For example, AI and machine learning is not the sole sort of area that I look into. However, am very interested in looking at some of the implications that derive from it. And so through, conversations and events like this has really helped to provide me with additional learning and insights. And of course, with AI, machine learning, and all of its sort of applications over time, we see a lot of them both in commercial and in healthcare, which is evident in this conference here. And so specifically for my doctoral work, I looked at how do nurses perceive machine learning decision support systems, and how do they see it influencing their clinical decision-making process at the bedside, which is something that I'm continuously fascinated in. So in aligning with the goal of this research, a qualitative approach was used, guided by constructivist grounded theory. And this methodology aligns with the research question because it allows us to look at the process or a complex phenomenon such as clinical decision making. And so for this study, I did 25 semi-structured interviews with nurses who are actively in clinical practice, inviting them to share with me what their thoughts are when it comes to AI and machine learning, and how will it change how they, or not, potentially, their decision-making within the clinical setting as they look after patients. So a little bit of a data analysis from a qualitative standpoint. It involves the concept of coding, which is, we don't use C++ or Python or R, but more NVivo. Anybody know NVivo? Oh, thank you. So NVivo is a qualitative thematic software. One of my friends in high school, he went into computer science, and whenever I say, oh, I code too, you should see the look on his face. He's like, Ryan, we're not the same. I was like, I know. So anyways. So, and so for the next little bit, I wanted to share some of the findings sort of separated in two different components. One being what were some of the things that nurses shared with me about how they look at machine learning within the clinical setting. And the second part will be how does that all potentially factor into whether or not machine learning predictions or suggestions will feed into their clinical decision making. So the first part is, well, what did nurses share with me about the perceptions of machine learning? And one thing I will start by saying too is during the data collection period, that is when ChatGPT became very, very popular over time. And so that was one of the common features that they will say, well, Ryan, is that what ChatGPT does or is it not? So I think from a wide, setting perspective, I think that really helped to generate some of the conversations in the clinical setting. So one of the first things was I invited them to share with me their current knowledge and understanding. And again, ChatGPT was the most common thing that came up during the interviews. And at that time, I was still trying to learn it myself. So we had lots of good conversations. But generally, nurses did share that they are not overly familiar with the exact mechanisms of AI machine learning, but they do recognize that it's probably embedded somewhere in healthcare, for example, in the EHRs or somewhere in their day-to-day living. And so because of that, they acknowledge that they do have experiences with things like machine learning, but not necessarily appreciating it to the full scope in terms of what it looks like in healthcare, recognizing it's there, but they don't necessarily are unaware at that time. And I think that really speaks to a lot of the implications later on, looking at, which I won't do a spoiler alert yet, but it does have a lot of implications moving forward. And so with their understanding at that time of machine learning, they shared a lot of the strengths and barriers and concerns. Well, one strength being time and efficiency that they were able to see. But at the same time, they see a lot of barriers and concerns, such as bias, privacy, and security, et cetera, which I think a lot of those elements were also touched upon in the previous presentations. And again, I will also acknowledge that this study was done outside of the other studies as well. So it was in a completely different setting. So it's interesting to see how some of the findings and recommendations do emerge. In terms of perceived applications and use, so there was a wide variation in terms of how nurses see machine learning being used. And for example, there were a lot of discussions about, well, should it be used in high stakes, rapid situations, or should it be in more long-term care, chronic, ambulatory care settings and scenarios. And in terms of the roles and relationships, lots of interesting comparisons were made. So, for example, do I see it as a team, such as falling under the concept of teaming? Do I see it as a mentor? Do I see it, as somebody that's just watching over me, making sure I do the right things? So, a lot of these came up of first part of the interview, was exploring the perceptions of what nurses think about it. And then the following up with those conversations was how does it influence their clinical decision-making process, which is one of the core questions I wanted to look at. And so through the series of interviews, we had categorized and began to have different categories that have emerged, looking at the different factors based on their responses of what may ultimately impact their decision. And these specific categories were not predetermined, so it kind of came up as the interviews happened and the analysis took place. So there were 4 main factors that we were able to identify that contributed to their decision-making of whether or not to adopt perhaps a prediction or recommendation made by machine learning. So the first one is the user, followed by the context, the tool, and the influence, and then of course leading to the decision. So for the next couple of slides, I'll provide some of the examples of each of these themes that fits into the overall question and their decision. So first of all, looking at the user. And so one of the questions that we began was, what do you think would influence an individual nurse's, whether or not, how likely, et cetera, to allow machine learning to influence their decision? So one of the things that really came up a lot was clinical experience. And, this covers a wide range of perhaps the area of their practice, how long they've been practicing, et cetera. And you can sort of, reading the transcripts and doing the interviews, you can really start to see how their clinical experience plays into sort of the other elements as well. But particularly, it also ties to their clinical knowledge and expertise. And so, for example, if they're very, very, seasoned in a particular unit or department, then that also has an influence of them as a user, not necessarily towards the tool yet, but as a user, and how they perceive machine learning and how it influences their decision making. One in particular also is their AI knowledge. So this is, again, at the individual user level. So are they familiar with it? And you can see how they're, there's no statistics necessarily involved here, but there is some form of patterns that suggest clinical experience, knowledge, expertise, and knowledge of AI. Only because, again, it's an emerging technology. So there's some patterns that we're seeing there. Of course, nothing official in terms of a correlation standpoint. Next is also the element of trust within the user. And this refers to their ability to trust technology in general and their ability or sort of affinity towards trusting any sort of new tools. And a lot of the trust examples that they've shared with me was how their trust may have been influenced in previous technology implementations within the clinical settings, and that trust continues to sort of translates over to any sort of new technology, which machine learning and AI being one. And of course, last but not least is from the user standpoint, any biases or assumptions that may have towards the technology in and of itself. And the next is the context. And so certainly the individuals that I've interviewed, they were all actively practicing in a clinical setting. And so one of the most common setting that they see AI and machine learning being used is, of course, within their own area of practice. But specifically, they were able to identify areas where they would see how, the context might influence whether or not they use machine learning or not. So one particular example a participant shared was she was also an emerged nurse, and she can see how perhaps in situations such as when we do stroke protocols or when we do cardiac arrest, then machine learning might take on a different role as opposed to another nurse working in rehabilitation, and how much of that machine learning prediction plays a role in that overall clinical decision making can, again, depending on the context. And of course, that will also depend on the specific scenarios and the requirements. So for example, knowing machine learning emphasis a lot and the strengths in predictions, it might be useful in short scenarios to predict risks and what things need to be done, but also in a long-term approach looking at what might be, coming up down the line. And again, these were all fascinating examples that the nurses have shared because again, based on my understanding and what they've shared with me in the interviews, their hospital has not necessarily evidently or shared with their staff that there has been AI or machine learning implemented. The next, in terms how machine learning plays a role in their decision making, is the workflow. How will this tool fit into my workflow as a healthcare provider? So is it something that requires me to log in to see additional predictions, or is it going to be embedded and integrated? Will the phenomenon of hitting snooze or dismiss continue to come back when it's sort of in the forms of warning signs, etc.? Because that often, again, contributes back to that alarm fatigue phenomenon, where is it something that will disrupt their workflow, or will it be something that actually helps to facilitate their workflow? And last but not least, the context of how machine learning is deployed over time and how it's implemented within the healthcare setting. So all of the participants almost unanimously share that there's always been things and technologies that are implemented, but there hasn't been a lot of ongoing support. So they reinforce the importance of, regardless of the technology, there should be more support when it comes to implementation and support prior to it being deployed. The next element looks at the tool specifically. And while the previous components of the user, the context, speaks a little bit about their understanding and perceptions towards the tool, participants in this question really shared with me some of the specifics about what they see from the tool itself that may either support or maybe serve as a barrier to them using it within their practice. The first one is features and characteristics. What does the tool look like? And that was a common question that was raised. Ryan, I don't know what the tool looks like or how it's going to look like. And in fact, how it's going to look like, to the next point of presentation, might actually influence whether or not I use it. And so then I followed up with, well, what do you mean how it looks like, and what do you hope to see? And so interestingly, a lot of them hope to see, well, Ryan, I want to see how it made that decision. So it just doesn't tell me, oh, you should do this, but how did it get there to that point? And I think that speaks to a lot of the conversations that we've had. A lot of the times in situations and in conferences and in papers, we see a lot of, how the algorithm was developed, the data sources that contributes to the development of the algorithm. But when we're practicing at the clinical bedside, we might not necessarily see how the algorithm came to be. What were some of the considerations? What were some of the factors? Even understanding the differences between, knowing what a test set is. So a lot of them do say, well, Ryan, ideally we would be able to see what were some of the factors that were used to consider, to put into this algorithm. And in terms of in addition to that, if it gives me options, I want to be able to see a visualization of, do I do A, B, C, and D, and sort of what their percentages or probability is. And I thought that was incredibly interesting because a lot of the times currently, I'll use sepsis alerts for an example. We'll mostly only see whether a patient is a risk for sepsis high or low, but we don't necessarily see what has contributed to it, other than our own understanding of what are the factors that contributes to sepsis or high likelihood of sepsis. So presenting the evidence of the algorithm itself, as well as some of the other peripheral and surrounding factors, that was something that nurses have indicated that would help them to perhaps lean into this tool or to integrate and use this tool as well as its recommendations in a more fulsome and more wholesome manner. And the last one is also ease of access and use. And this speaks a little bit to the workflow as well, but that also refers to, are the functionalities of the tool or the information that is presented, are they easy to access and use? So for example, if, as part of the visualization, if lots of graphs and charts were presented, it might not be easy to interpret and understand. And in turn, that might limit some of the potential or likelihood for nurses to consider more within the context of clinical decision making. And last but not least is, of all the different factors, user, context, the tool, this part of the influence, look at what are some of the other considerations either collectively or some of the additional factors that will influence my decision to adopt machine learning or AI algorithms and predictions in my care or not. And the first one was tension. And one of the most common things that was shared with me was the tension between me as the healthcare provider and the tool. Is it a competition? Is it to see who was more right? I predicted this is what the algorithm said, et cetera. So there's tension between the two, quote, parties, if I may. And there's also tension between the nurse's role or a healthcare provider's role, and then the environment. So is there any sort of policy or regulations that either forces me to use it or not, or is there any other recommendations? And that also feeds into the concept of responsibility. So if there's a mistake, who's responsible? And that was a very common theme that was shared with me. And then again, that also mimics a little bit of tension and as part of that decision-making process. So it's sort of looking at, is it me, is it them, what's responsible? And that can take some time as well in the clinical setting. The concept of reinforcements was one of two that was sort of a surprising finding to me. The first one was reinforcement. And how it was sort of came about was, nurses who were participating in this study shared with me, well, Ryan, if I continuously to make my own decisions and the predictions of the machine is, the same as mine, then I am much more likely to continue to use it over time. Certainly there are some considerations to that is, well, what if one of those times moving forward it's incorrect, but because of this positive reinforcement, that you're more likely to just follow along. Similarly, the negative reinforcement was also something of interest, and it was, of course, if there were discrepancies between the decisions that were made. However, without the visualization or the evidence, then the healthcare provider might just think, oh, the machine's wrong, I'm right, and continue to not use it over time, and maybe not necessarily recognizing that the healthcare provider might have made a mistake. So that's something that was very of interest to me. And the last one was choice. And this came up, I believe it was halfway through the interviews that I conducted. And finally, through a couple of the interviews, the concept of choice came up, and I started to ask in some of the interviews that, well, should nurses and healthcare providers be given a choice to use AI or machine learning in their care or not? And as a nurse, we the nursing profession often has very strong feelings towards technology because it's always a fine balance. And I think this applies to all healthcare providers as well, between technology and sort of the human nature of the care. But, after I started asking the first participant halfway through, and every participant afterwards has said to me, well, Ryan, actually, no, we shouldn't be given a choice. If the decision at a healthcare organization is to use it, then all of us must use it, and it has to be part of the care. And so that to me was something very, very interesting, because what it spoke to me was they already then see it, given some of the potential, is that, well, regardless, it should already be part of the care, and I, as the individual provider, should not be given a choice to whether or not that tool being used. How it informs my actual decision is a completely different story, but it should be there. And so that was the argument that they had provided. And so all together, putting it, all of the factors from user, context, the tool itself, and the influence, all of them contribute towards whether or not nurses would or would not, use the decisions or predictions from AI in their actual clinical decision making. So based on this, I want to share just a couple of points in terms from a discussion and implications perspective, and hope that will generate some additional conversations over time. And so, for this study, one of the fascinating components from my own learning and my own research is that how we were able to apply a qualitative method to a traditionally very quantitative computer science topic such as AI and machine learning, and to provide insights from that. And I think, through attending conferences and reading papers, what I do see is that there's ongoing more and more opportunities to have some of this work to complement some of the more technical aspects of machine learning. And the importance of interdisciplinary approaches. Similarly, as I shared my story with my high school friend, I certainly couldn't do what he does, and I think he might be able to do what I do. But there's always conversations working with interdisciplinary, and I think that also extends within healthcare. So nursing, medicine, psychology, social work, all of those different healthcare disciplines, but also outside of the disciplines, data scientists, computer scientists, engineers, etc., because really it's such a complex issue and phenomenon, but also with lots and lots of opportunities. So I think there's, for me personally, I would not have been able to at least arrive at this topic without the work of data scientists and engineers. And I also don't see a lot of opportunity for me to advance this work if I don't sort of, work outside of my nursing scope. So I think that to me is something really important for me personally to recognize. And I hope that will continue to be a trend that we see in this research. And then of course, there's so much potential and growth when it comes to AI. And I think, clinical decision making is certainly only one very small component. But for me as a healthcare provider, certainly clinical decision making is something that I do all the time. So it plays a significant role in my personal work. And then always opportunity to leverage and optimize AI applications. Certainly more and more literature are, having examples of how AI is used. So from the keynotes example to the examples provided here. And so there's just lots and lots of application. And then potentially there's lots more opportunities for more of this research moving forward as well. And then to this, sort of theme of this symposium, looking at clinician-AI teaming, I think it's a great opportunity, and I think it's a fundamental quality component moving forward for quality interventions involving the two together. And then I think we're all here and all doing this work ultimately to promote patient safety and care outcomes. And I think all of this summarizes the importance of conversations like this and to be able to meet and learn of others' work in achieving that goal. So with that, I would like to thank everyone and I think turn it over to the chair.
We only have like 10 minutes or something like that before we have to wrap up. So I don't know if there's folks that have something that, a burning question or something that you would like emphasized or discussed more. And also thank you very much to the presenters.
And thank you all for staying for lunch.
Is this, okay, it is already on. It's actually a question for Ryan. Sorry to make you keep talking. So, as I've started getting into like clinical research, something that I've been told a lot is the first people you need on board are the nurses, right? Because they're the backbones of the hospitals and they're the boots on the ground, right? They're the one who are gonna make sure that things are implemented correctly. And so I'm curious in your own experience within these hospital systems, as the organizations have started implementing things like machine learning or even digital health tools, are you finding that they're approaching it correctly, or are you finding that there is sort of a lot of tension happening between nurses or other staff with these things being maybe forced on them? I'm just curious to hear your thoughts.
Hello. Oh, hi. Thank you very much for the question. Excellent question. I think in my own experiences, there will always be tensions when it comes to any form of new implementation of anything new, regardless if it's technology or policies. So one example I remember is every time there are changes to tools, such as even with the medication administration record, et cetera, there's always tension. And a main source of the tension is it comes down to workflow. And I would say, in working in the emergency department, our workflow might differ a little bit from unit to unit to unit. And so I think to your question, there is always tension. And in part of my interview, some of the participants shared, well, what are some examples? It would include things like early consultations and demonstrating the value. And one of the ways I think I had mentioned as well, if they recognize the value of the tool, and sometimes it's, beyond the patient safety umbrella, but specifically for machine learning, perhaps it's seeing how that tool influences me and how it supports me specifically when it comes down to the visualization. So then it makes sense. It's then seen as, oh, it is actually supporting my role and not necessarily one additional thing that, disrupts my workflow. So to your question, yeah, I think there's always tension, but there might be ways to mitigate some of it over time. So, thank you.
What I might just add to that is in the broader clinical informatics space, there's this growing trend of having, I think many of you know of the CMIO role or CNIO role, and then having governance tables at organizations that represent clinicians. And so as we advance in the digital psychiatry space and use more of these technologies at the bedside, can we leverage those pathways that have been created for other purposes, often around the EMR, EHR, but that a lot of that implementation work is done. Can we leverage it for some of the other kinds of technologies to get that buy-in early on?
Thank you all for the interesting talks and the important work. For the first three presenters, many of your studies seem to force a choice between deploying police and deploying medical services based on perceived risk of violence. And that seems to also force an assumption that police are always best equipped to respond to situations that may involve violence or risk of violence, rather than considering clinical context. I'm just curious what your thoughts are about that and how you settled on that method.
Thanks. That's an excellent question. So, so that sort of forced choice paradigm is definitely an artificial scenario. The key factor that we're interested in is this assessment of violence or aggression. And so by no means are we suggesting that police are the kind of appropriate resource necessarily. It's more so that in those kind of experiments, we're trying to understand people's decisions about whether or not there is a risk of violence or aggression. And that is sort of the key construct that we're interested in measuring. And so police really, the participants are just instructed to deploy police if they believe there is a risk of violence or aggression. And so that forced choice paradigm is really trying to get at that perception of risk. But the resources to be deployed are just kind of used in that artificial experiment scenario to kind of prompt some sort of a decision about the kind of outcome. And so that we actually have like an outcome to measure. But the involvement of police in mental health scenarios in the community is a very contentious topic. And some of the work around the machine learning study and police involvement in admissions in psychiatric care, we've actually been in kind of connection with police services in Toronto about that finding, as well as in the acute care units at the hospital, just to communicate that and try to understand whether police involvement at admission is a good idea necessarily. Yeah, I hope that answers your question. I don't know if you guys want to add anything.
I don't have a watch, which I should have.
I think
a watch.
we're
like
5 more minutes,
Okay.
so we have time for maybe one more question, or we can also wrap it up.
I might just ask a sort of a quick fire question and then we can wrap it up, which is, think about what you presented today and the implications for implementation. Do you have any thoughts on how the work that you've done could be used for organizations that are implementing decision supports in this context? And it could be like just one, and then you could pass it on.
Something I think I've learned from this experience is the importance of being educated on the tool that you're using. So the importance of, if AI is going to be implemented in healthcare settings, that the individuals who are going to interact with it and use it are properly educated on how it works, its potential pitfalls, and how to critically engage with it, so that you can avoid, you can essentially promote productive mistrust, which is essentially a term that means that you know what the AI is capable of and you know its abilities as a tool, but you also know not to overly rely on it. And essentially the implications of over-reliance on AI that can be biased is just extremely serious in healthcare settings. So being able to emphasize education before implementing it is important for me.
Yeah, I think for me, like something to consider for organizations would probably be that like not everyone is going to use the AI recommendation the same way. Like some people might not like look at it at all or like rely on their own thinking. So I think there's like a lot of differences to consider in that like usually like if an AI system were to be deployed, it would look the same across all the devices, but obviously like the way that it's used would differ, and as a result, like the impact on the patient would also be very different. So it's like really hard to generalize like the impact of that, and like I guess like looking at like the HCI, like human computer interaction factors, like hopefully we can like be able to evaluate the individual like differences and how like each patient is affected differently. Sure.
I think from my perspective, when it comes to perhaps implementation or expanding on some of this work, would be ensuring some form of fail-safes or safeguards are in place as sort of the technology becomes more and more advanced. The closest example I can relate to at this time would be, when the clinical documentation system has a downtime, then it seems like everybody is relearning how to practice at a particular moment because there's no more prompts, everything is self-driven. And I think when it comes to AI and that clinical decision-making is, well, we want to ensure that, it doesn't do too good of a job to actually take that clinical decision away, especially for perhaps for care providers on different spectrum in terms of clinical knowledge and expertise.
And I think for me, the importance, I'm a researcher, so I'm going to talk about research, is just conducting research into, clinician AI interactions, because we can, as you said at the beginning, we can develop perfect systems, but the way that humans use them may not be. And so we really need to understand the factors that kind of contribute to that use.
And that would be my take-home message to our CEO or our CIO, is that we can spend all this time on the model development side, which is so important, but we have to have some resources to support on the other end as well. And that's my take-home message for today. Summarizing something that was complicated and making it one sentence. So thank you very much, everyone, for being here today, and thank you to the symposium presenters.